So ALS, or Lou Gehrig disease, it's amyotrophic lateral sclerosis. This is a progressive neurodegenerative disease that affects the cells in the nervous system, particularly the motor neurons of the brain and the spinal cord. A lack of muscle nourishment that leads to muscle atrophy or wasting away. And then sclerosis is scarring and hardening, and you'll see this in the brain and the spinal cord region. And it's the sclerosis that ultimately leads to the loss of breathing and to death with individuals with Lou Gehrig's. So there's two kinds of Lou Gehrig's. There's sporadic and then there is genetic, but it's the sporadic that is mostly the type that you'll see, like 90% of the cases of Lou Gehrig's is sporadic, and there's no known cause. There's only one medication that is approved by the FDA to treat Lou Gehrig's, and it can prolong life by only a few months. So that really doesn't seem like a very promising medication. And it's Riluzole or Rilutec. And so most of the medications that patients will be on who have Lou Gehrig's are going to be medications for all the symptoms that are possible that come along with Lou Gehrig's, and then also for psychological disorders, because a person with Lou Gehrig's, their body literally falls apart and they will not be able to eventually breathe, but their mental capacities are retained for the until they die. So their awareness of their losing all of their functions is acute. I mean, they are completely aware of it. And so the anxiety, the fear, and the depression, I mean, just would be overwhelming. I can't imagine. So often patients are on many medications to deal with the various symptoms and complications. It's really palliative care, keeping them as comfortable as possible for as long as they're alive, is really the goal with someone with a diagnosis of Lou Gehrig's. So life expectancy is about 3 to 5 years. Starts with muscle weakness and stiffness. Those are some of the first signs. And then it's just sort of a kind of one effect after the other of paralysis and wasting away, limited range of motion. Your fine motor skills are increasingly difficult, and it just sort of progresses and progresses until the individual is eventually dependent on a ventilator to breathe. So before they get to a point where they're, sort of bedridden and on more or less hospice care, things that the dental hygienists can think about in if they come in to be a patient would be xerostomia due to many of the medications that they'll be on. They may also have excessive saliva, but this is due to their inability to manage their normal saliva production. So it's not that they'll be producing extra saliva, they just may not be able to manage it, swallow it, get it, clear it out of the oral cavity. So a patient in earlier stages, if they come into the dental office, they may have to be in more of an upright position and not laid back flat. Dysphagia is going to be weakness or difficulty swallowing due to muscle weakness. Shorter appointments, frequent breaks, and the use of a bite block are appropriate choices for these concerns, because we're probably going to have to help them a lot with the liquid, managing the liquid in their mouth, saliva and other water, and then so suctioning and then helping prop open their mouth, because it may be difficult for them to keep their mouth open. They could have sensitive gag reflexes, so we have to consider this with taking x-rays or anything that is going to go farther back in their mouth, but especially with x-rays. Depending on their stage, difficulty speaking and communicating, helping modify toothbrushing techniques with all the different modifications, and then giving self-care instructions to the patient and also to a caregiver. And then all stages of the disease, a power toothbrush, inner dental aids, fluoride, frequent preventive care appointments will be beneficial. So as long as they can come in, frequency of appointments are going to be important. And then the dental hygienist always has a role, even in bedridden palliative care. We've talked about this with our aging population, but anybody who's on hospice or strictly on just kind of palliative care still, deserves to have treatment and oral care for someone who comes maybe to their bedside to help clean their mouth on a weekly basis, or even if it's a monthly basis. So the hygienist should always consider themselves part of the care team, even when somebody is very close to death. So Huntington disease is another very rare, complex neurodegenerative disorder. It results from degeneration of neurons within the basal ganglia, the area deep in the brain that controls movement. So Huntington disease, or HD, also affects the cortex of the brain, which controls things like thought, perceptions, cognition, and memory. So unlike some of the other, unlike Lou Gehrig's, some cognitive function is impaired with Huntington's disease. The symptoms can include changes in personality and mood swings and depression, as well as impaired thinking and judgment, slurred speech, dysphagia, weight loss, and chorea. And then there's 3 stages. There's early, middle, and late, and it is ultimately fatal, and at present there is no cure for Huntington's disease. Some considerations for patients would, of course, be xerostomia due to antidepressants or antipsychotics they may be on, increased caries risk because of xerostomia. So we want to think about our protocol for this. As the disease progresses, there will be dysphagia or difficulty swallowing, assistance with transferring a patient into the dental chair if they are in a wheelchair, positioning the back of the patient chair more upright to help them tolerate fluids, limiting the ultrasonic and any liquids, and being just really on top of suctioning so that choking is not something that happens. They don't choke on their saliva or the fluids. And then they're at an increased risk overall to dental disease, so we want to think about frequent dental visits, and then planning with the caregiver about how their oral health will be addressed after they can no longer come into the dental office readily or easily. So traumatic brain injuries and post-traumatic stress disorders. Traumatic brain injuries is caused by an external force that results in disruption of normal function of the brain. So we think of accidents or, related to automobile accidents or sporting accidents or, on the job or, maybe in war or anything where they're in danger of injuring their brain, whether it's from doing something fun or job related. Leading cause of cognitive, behavioral, and physical disability is traumatic brain injuries. And then psychiatric disorders such as post-traumatic stress disorder frequently occurs following a traumatic brain injury. So the trauma of the event itself, whether it happened during war or a horrible car accident or a horrible skiing accident, it causes post-traumatic stress. And so that's sort of a secondary thing that must be dealt with. So you can only imagine with the medications that xerostomia is going to be an issue, and so we want to follow our protocol for xerostomia. This is going to come up over and over and over again, so it doesn't really necessitate us saying the same things, but so I might refer to it just as the xerostomia protocol, but we think about our kind of go-to fluorides, xylitol, saliva substitutes, increased visits to check for things like mucositis or increased caries or, any of the things that you think of when you think of all the benefits of saliva and then not having that saliva. And so all the things that can go along with that. So additionally, though, individuals with traumatic brain injuries or post-traumatic stress, they'll need the assistance with their emotional stability. So then that's partnering with other healthcare providers, family members and caregivers to see what helps the patient feel comfortable, stay calm, be reassured, and what sort of things can the hygienist do to help the patient in all those aspects. So involving the family or the caregivers, talking to them about the treatment plans and the importance of their overall oral hygiene regimen is really important to kind of help the patient maintain health, but to also feel comfortable and kind of gain trust with their healthcare provider, their oral health care provider. So specific protocols for patient management depends on the extent of the injury and the therapies involved. It could be a minor, brain injury that just involves like forgetfulness, and so how do we help this patient forget or remember to do these different things to help keep their mouth healthy? Or it could be very severe that leads to seizures or severe mood disorders or something that's more complicated. Non-pharmacologic treatments for PTSD include cognitive processing therapy and prolonged exposure therapy. There's also prescribed drugs that may include antidepressants, antipsychotics, and sedatives. And of course, those are going to increase xerostomia. Patients with spinal cord dysfunction would involve spinal cord injury, motor and sensory inabilities or deficits. Causes would be from injury, trauma, or disease. Male 16 to 30 are at higher risk because they're usually more physically active, may lead a daredevil type lifestyle. Symptoms vary depending on level and type of trauma. Physical therapy and counseling would be two big areas of therapy, and then ventilators, individuals that have to use ventilators because of either complete paralysis, they're at a greater risk of aspiration pneumonia or ventilator pneumonia. And then pressure sores are a major concern. So they have to move a lot. Someone has to help them move so that they're not developing pressure sores from just constantly sitting in one position. An individual that's in a wheelchair may be treated more effectively in their chair. So oftentimes if somebody is paralyzed, we wouldn't want to actually move them. They probably are catheterized or have some kind of a bag, and we don't want to disrupt that at all. So oftentimes if they're paralyzed, we would just want to treat them in their wheelchair. Individualized care depending on their specific situation. Oftentimes individuals that are paralyzed will use a mouth-held appliance, and this is something that they can use for a number of different things, such as turning the page or on a Kindle or a tablet, or using a computer or the keyboard, or a number of different things. Use a mouth stick to paint with, or to write, or to tap something that gives them the ability to use some kind of a device. And then, so we have to think about, are they clean? Is that mouth stick or that mouth-held appliance getting cleaned? Is it causing any kind of irritation or trauma in the mouth? Does the caregiver know how to maintain it or clean it? And then is the individual using something such as fluoride or daily xylitol to help them with their increased caries risk? And then who is helping them with their oral hygiene? That's a huge, if they don't have use of their hands, does their caregiver understand how to maintain their oral health? Okay, so we're going to stop at seizures again, and we will pick up in the next video.